Hello, everyone. Good afternoon. I'm Dr. Nikita Lad Patel. I head the Apollo Fertility Navi Mumbai. I'm going to talk to you all today on what next after an IVF failure. So sometimes, people come with 2 IVF failure, 3 IVF failures. What should be the next step and how do we handle that part? So it's very emotionally very tough for a patient because she goes through the procedure wherein you stimulate her for 10 to 12 days, retrieve her eggs. We talk about how good the eggs were, how the good the embryos is, or what's the problem with the sperm. And after everything, we decide the grade of the embryo, whether it is a grade A, grade B, grade C, whether we are transferring a day 3 or a blastocyst. With all this, if we tell her we are going to transfer a beautiful 5AA blastocyst, and still, if she does not conceive, it's very tough for a patient. You get me? It is like, we have told them that the uterus is right, this embryo was perfect, and why has she not conceived? At that moment, the patient cannot, she needs the answers. And when we cannot give answers, it's very tough for them. So what do I suggest? Go get back. Well, like we have a patient who's failed IVF, we go back to the protocol. What were the drugs used for stimulation? How many days did she stimulate herself? Well, how were the embryo quality? How many embryos were formed? Was it a oocyte problem? Was it a sperm problem? Get your embryologist with you. After a complete discussion, we figure out, if I feel, my embryologist said, ma'am, maybe the stimulation, the egg quality wasn't good, I would stimulate her again for the next cycle, get a good number of eggs. Again, go ahead, check the sperms. If there was some, do a DNA fragmentation test. Was the sperm fine? If he's smoking, tell him to stop tobacco, because that increases the ROS and causes, bad embryo quality. If the embryo quality is good and still she's not conceived, if you go for every step, you can do something called as pre-genetic screening or pre-genetic diagnosis of the embryo, PGD. There are two ways. There is an invasive and there is a non-invasive one. So in a non-invasive one, we let the embryo come to a blastocyst stage and let the cell-free DNA be released in the media, and we take the media and send it for testing. We check how the embryo, what the media, how was the embryo. If there was any defect in that embryo, is there is any trisomies or aneuploidies seen, we do not transfer that embryo. So we wait for a healthy embryo, transfer a healthy embryo back into the uterus, again after a pre-genetic screening. So sometimes even when we do not have any answers, again, what is wrong, go for a uterus, check the uterus. Sometimes we see in the uterus, when we do a hysteroscopy, there is small polyp or a small septum which does not allow an implantation. So you need to even figure out, is there a problem in the uterus? So do not miss any steps. It's not like, you have good embryos frozen. Sometimes you need even to take just breaks. It's like, 2-3 breaks, and you will come to know, fine, I have good embryos. And then, make it take 3 months. Sometimes patients are like, oh, I did this cycle, it failed, I don't care, I want to go for a second cycle the next month. Your body needs its own time to break. Take 2 to 3 months, go for a holiday, let your mind again come back to normal, and transfer the embryos back. What happens is, there's a window of implantation, like everything is fine, like I said, the embryos are good, the quality. We do not know what is the window of implantation. Sometimes it can be from the day, in natural cycles it's about 2 to 5 days, but when we do an IVF, it's about 12 to 48 hours to 72 hours. So in that, the window of implantation is very important for the embryo to get hold and stick to it. So when we transfer the embryos, when you have too many failures, you might be hearing doctors saying, let's go for a sequential transfer. Why do we do a sequential transfer? Because we do not know the window of implantation. So what will your gynac do? They will take the fertility specialist will transfer an healthy, the best embryo on day 3, and again wait for the other embryos to turn to a blastocyst and a day 5. So that's called a sequential transfer. That is, in the same month we will have 2 transfers, a day 3 transfer, a day 3 embryo, and a day 5 blastocyst. So whichever the embryo, the window is open, it will help in implantation. So remember, there is something called a sequential transfer. If you've tried everything, you've done PGS, you've checked for the embryo quality, every step is fine, and still it does not implant, then we have to think about what might be the cause. Last option sometimes is an uterus which is not holding on. You need to go for surrogacy. So with all these steps, with everything, have patience, because you to conceive IVF, wherein if there is a problem like a sperm count is low, We know we need to do sometimes not only an ejaculate sample, we need to do an TISA, wherein we put in a needle into the testes and retrieve the sperms. So we can do that. Secondly, if the egg quality is bad or the egg reserve is really poor, we call something called as an embryo pooling, wherein every cycle, maybe this cycle I retrieve the eggs, maybe after a month gap again I retrieve the eggs, create the embryos. I have a good embryo pool of embryos with me. I can, after that, in low egg reserve, it's very tough to do a pre-genetic screening because I do not have good number of embryos. Here, if I pool the embryos, go to the blastocyst stage, and then I can test them which one is healthy and transfer them, or wait for a blaster to be formed and transfer the healthy embryo. So low egg reserve, try the embryo pooling. In a polycystic ovaries, you find too many eggs. But when you form an embryo, not all, if you get even 30 eggs, sometimes you do not get 30 embryos because the quality of the oocytes really differ in an PCOS patients. But whatever healthy embryos are formed, transfer the, let them go to a blastocyst stage and then transfer them. So if always freeze all in a PCOS patient, the best way to get the higher result is, because you have stimulated her naturally, only one egg grows in a natural cycle. In a PCOS patients, when I stimulate, there are about 10 to 10 eggs on either sides, follicles. So when I inject them with hormones, all of the eggs will grow together. So imagine 20 eggs are growing together. So in that, there's a lot of hormone disbalance. So when I retrieve those 20 eggs and create the embryos, I need to freeze because I do not want her to go into an hyperstimulation. And secondly, I need that patient has to go down, suppress her. After 2 months, we can transfer the embryos back into her. So in a PCOS patient, always better to freeze the embryos and then transfer the healthy blastocysts back, which will increase the chances of pregnancy. Endometriosis, chocolate cyst of the ovary, wherein we see a lot of adhesions, everything is stuck up. Patient is complaining of severe pain during menses, dyspareunia while having relationship, severe pain, little brown discharge. That's a chocolate cyst of ovary or endometriosis. In these cases, again, the egg reserve is down or the quality of oocyte is really hampered in an IVF cycle. So you try to again stimulate her, retrieve her eggs, hopefully get good number of eggs. If there is a cyst seen, a chocolate cyst seen, before you retrieve the egg, if the chocolate cyst is less than 3 centimeter, and you can see the antral follicle count, that is the AFCs above the chocolate cyst, wherein you can go and retrieve the eggs, that's a great sign. Then you can go remove the eggs before operating, because whenever you operate the chocolate cyst, there's going to be little bit of ovarian tissue is going to be handled, and the egg reserve is going to drastically go down again. So I prefer in an chocolate ovarian endometriosis or chocolate cyst, first retrieve the eggs if you can, that is, and then go ahead for the surgery and then transfer the embryos after giving them depot injections for 2 to 3 months, which will increase the chance of success. So what may be the cause, you have to find out and then go ahead and treat it accordingly. Now if you see a lot of azoospermia, zero sperm count, in that we do few tests in the husband, like Y chromosome microdeletion, karyotyping. If everything is good, we can do TISA, that is, we put a needle into the testes and remove the sperms, or we can do micro TISA, that is, we put in the needle, open the testes, check which is the best tubule, remove those healthy tubules, little bit of tissue, and send it to the embryologist. They will check in the tubules whether there are sperms. We will use those same sperms in the same cycle where we have removed through IVF removed the eggs, and each egg will put the embryo sperms into it, inject and do an ICSI and create the embryos. That also gives you a very high chance of success. But in these cases, sometimes the blastocyst is not good. What is, so that you have to check, because if that is causing an IVF failure again and again and again, sometimes you need to go ahead with a donor sperm if you tried everything and has not worked. And remember, sometimes even the uterus can be, like I said, the receptivity. So there is something called as an ERA, endometrial receptivity assay. So your fertility specialist will tell you, go for an ERA, wherein what we do, we try to see the natural cycle and we remove the endometrial tissue and check whether the implantation rate highest is which day, and accordingly we transfer the embryos back. So these are all the options what we have, and we can go ahead and try one of these options and try to increase your success. And if anybody has any questions, they can please put in their questions on the chat box, and I can keep answering while I'm talking. And so if you've gone through an IVF cycle, you basically know how the cycle goes, how the process is. And remember, do not lose hope, have patience, because the main thing is it takes its own time. When you will be able to conceive, we do not know. Like I said, we have to go back, sit with your fertility specialist, know what is the right way, how to go about the process, and how the procedure will go ahead. And remember, embryo quality, endometrium, semen, sperm count, semen culture sometimes we need to do, wherein there is some abnormality or there is infection in the semen. We have to treat it before we transfer the embryos. So we treat, sometimes the semen infection is there, we treat them with an antibiotic and the count improves. If sometimes people have thyroid, you have to treat the thyroid levels, everything, the hormones, like in a female also, thyroid, prolactin, AMH, the FSH, LH. You have to check these basic hormone tests in the fertility and decide if the AMH is low. That's okay. So I have seen even a low AMH for conceiving naturally, even with an IVF failure. But in that case, if the patient is young, one. Secondly, her FSH should be normal. Main thing is, remember, in a low egg reserve, FSH reports are very important, because if the FSH is high and the AMH is low, we know we don't have a very good chance of getting the good quality oocytes. So you need to figure out everything, go to the ground level, figure out what is the reports, how do we go about, what should be the next step, get the results accordingly, transfer the embryos, get the good quality oocytes, good quality sperms. If there is an issue, talk to the patient. You have to figure out whether you have to know what is wrong. If the eggs are bad, can I try with something else, or should I try stimulating myself again the second time? You should talk to your fertility specialist about that. If the egg quality is good, then yes, I would suggest them to not think about a donor. Always try yourself, because till 40 you have a very high chance of your own eggs giving you results, even with a low egg reserve. So sometimes some people just say that, oh, I tried, I heard my AMH was low, I did not give myself a trial at all, I went for a donor cycle, that failed. So I would suggest that do not do that. Wait, hold on. You can directly go ahead and start try 2 to 3 cycles of your own with your eggs. Like I told you, embryo pooling, that will give you your highest chance. Even with a low sperm count or even a zero sperm count, we have these options of TISA, micro TISA. Do not ever give up very soon. Don't think that oh, it's over, I cannot now conceive, the sperm count is zero, I need to go for a donor. Yes, if the money cost is a big issue, that time we do not, or the female, the wife cannot go through and retrieval, or she has some health hazard, yes, that time a donor sperm IUI, just like natural relation, that helps out. But otherwise, you can't give yourself a self complete cycle with genetically, biological, your parents, you being your parents, like the sperms with TISA, your wife's own eggs create the embryos. Sometimes people are so confused. They think IVF, is it my own embryo, or people are changing? Nobody does that, because IVF has to be. Why do you do an IVF? Is for your own eggs and your own sperms. The DNA will be your own. So, so even surrogacy, when you had to do because the uterus was at fault, that time also it's your biological, your own child. So remember, you have to stimulate yourself. Even if you're fine, the wife is fine completely, but the husband's count is low, or his zero sperm count, he needs to go through TISA, the wife has to stimulate herself. So many patients ask me, can I just do TISA and put the sperms inside the uterus like an IUI? No, it's not possible, because for an IUI there is some basic count less than 20 million, it is not going to help us. So you have to have a more than 20 million count semen analysis. And where we have 5 million, 2 million count, or even zero sperm count seen, we cannot just do a biopsy, get the sperms and put it inside the uterus. We have to go through a whole process of IVF to get the pregnancies. Sometimes we have seen the results where it's dropped, the uterus is not being checked. So you have to check for the endometrium, go in, dilate the cervix, there's a lot of stenosis, check for the endometrial biopsy for tuberculosis, or a histopath result of the endometrium to find out whether there is any problem in that. So you need to rule out each point, go back, always, like I said, go 2 steps behind, go to the basics. What was wrong? Is her thyroid normal? Where there is any mistake, or if is everything good, then you can plan, like I said, let the embryos be frozen, take 2-3 months gap and come back for a frozen transfer. And if everything worked out and you have sometimes abortions wherein a third month or a fourth month where the cervix sometimes just gives way. I have patient one who could not hold on her pregnancy, so we do an laparoscopic os tightening before transfer. So the os tightening is done, then we just go ahead and transfer the embryos, and that has also given results. So there are many options how we can go ahead and hold on the pregnancy till term. So we have even seen patients sometimes deliver twins. One have been delivered and other one just, the patient had severe pain. We tried everything to not let go, that she shouldn't deliver. But when she went into labor, she delivered one. Second one, just she suddenly went, she had no contractions, everything was fine. We did then, os tightening, closed up. And after that, we transferred let the pregnancy go on. That same one delivered early at 20 weeks and the other one continued till 9 months and delivered. So always have hope, do not give up. We have all the options. Remember, IVF has 35 to 40% self cycle. I'm talking about. You have to know this and jump into it. Nobody can tell you there is 100% guaranteed in an IVF cycle. You know the realistic figures. If you're younger, yes, till 50% you have a higher chances of conceiving in the first cycle. Sometimes you have to be ready to go ahead with a 3 cycle IVF wherein we retrieve the eggs and create the embryos and freeze. So first cycle is done, we are lucky. We have more frozen embryos. Even if you've delivered once, after 2 years you can go ahead to your fertility specialist. Your frozen embryos can be transferred back and get the second baby, so you do not have to go through the whole stimulation cycle again for the second time. So we have all the options. You have very high chances of conceiving because natural conception is 7%, only 7% of the population when they are undergoing, 7% when they're trying in the whole world conceive naturally, only 7. Then after we see so much of population, we think it's so high fertility. No, infertility is also increasing. Secondly, with an IUI, wherein we just wash the sperms and leave it inside the uterus, we have 15% chances of conceiving. 15%. And IVF, depending upon the cause, you have 40 to 50% chances of conceiving. So remember, the IVF gives you a higher chance. IVF exceeds the higher end, wherein when the sperm count is low, we go ahead, we retrieve those eggs, and we do the ICSI processes, wherein in the eggs we take the sperms and we create the embryos. So this is another way wherein we have a higher chance of giving the pregnancy. Like I said, when we do TISA, micro TISA, we have to go ahead with an ICSI. Anybody has any questions? So like I said, this is very emotional. Infertility, have an understanding between an husband and wife. Both of y'all should understand the process. Both of y'all should be together during the whole IVF cycle, because this is not going to be only her, she needs a lot of support, mental and physical. So it's like finances are going, because this is an expensive process, we know that. But mentally you have to support your wife, because it is such a it's disturbing for her, because most of the process is going into the female. That is wherein we stimulate her for 10 days. We are getting her eggs retrieved, everything is into her when we transfer the embryos. So physically and mentally, it's very tough for these females to go through and say, oh, I did, it's okay. For us it's very easy to say it's okay, it didn't happen, try next. But it's not. It's very emotionally disturbing for the female. And I would suggest that support the female as much as possible, a complete family support. We all know it's 50% chance, but you cannot just explain that why when it fails. It's very tough for the female, emotionally and financially, very draining. Like I said, what is the reason they kept wanting, any couple, or even if we are in that, we would want to know what is the reason, why is it not implanting. So like I said, we keep going ahead with all these further investigations and in test, and we hope to figure out the reason for implantation failure. So I hope I could help anybody with this process. And if anybody has any questions, they can put down later, I can reply. Thank you guys, and have a safe day. Bye.